بس وخليه يظبط ويمكن يعكس. بص يا فلوس الشاشة تبقى موجودة مجرد كل ساعة بس إيه عشان ما نعملش لوك تاني. لا إله إلا الله.
شغلة هلا أمي شيلي هي رح أشوفها تمام. خليكي بدي أنا بشوف، رح أسأل الممرضة عنها وبجيب لك إياه وتشتري. شكرا فيك. سوا للبيبي. المشكلة بدي أقول رفيف خلينا نتسلى شوي هلا قبل شو يا بنتي؟ أمي ما عاد فيك أتحمل بدي شوي. تمام يا عمري هلا بشوفه يلا. أنت ارتاحي شوي يلا حبيبتي يلا بس دقيقتين يلا. لا تاكليها. أنا عملت اللي بيطلع بإيدي. لا تلومي حدا على اللي صار. وأنت اللي قلتي لرفيف إنه هو الحقيقية. بالبداية أنت ضحكتي علي. مساء الخير. أهلا بيكم. احنا لسه بس عشان بس شوية حاجات لوجيستيك كده والأتوبيس جه متأخر، فاحنا كان المفروض نبدأ 2 شارب وبعد كده هنبدأ 2:30 شارب وشكلها هنبدأ 3 إلا ربع شارب إن شاء الله، فهنتأخر ربع ساعة لحد ما الناس يبقوا موجودة. يس. أهم حاجة السبيكر بتاع السيشن الأولاني، السبيكر يكونوا موجودين لأن هنبدأ إن شاء الله. أنا شايف الدكتور أحمد. Good afternoon. I just would like to, I can see Dr. Arcadius and Dr. Omir. I think you are all, you know Dr. Arcadius from Italy. We are glad to have you with us. And Dr. Oram. Oh, yeah. Also, we have Dr. Omar with Arabic and Omir with Turkish. Nice to have you, sir. Just will start 2:45 sharp, hopefully. تمام؟ شكرا. الولد كثير منيح بس هو هلا نايم رح يجيبوا لك اياه بعد الشغل. طيب بابا ديما شو كان بتذكر؟ قلتي ديما؟ ما بعرف ما شفتها. كيف ما شفتيها؟ والله كانت نازلة على الكلاش. لا بنتي أنا إلي زمان وقت هون، يعني لو شفتها أو إذا كانت هون ليش لخبي؟ يمكن تكوني شفتي حدا بيشبه. اتفاق وفي وعد. ايوه شكرا يسلموا عليكي كثير طيبين، بس ما عاد في نسبة شربانة 3 كاسات. بنتي 3 كاسات صغار، خدي هذا بدل حليب الام. لا يا خالي، المغلي هو اكثر الحليب، اشربي مغلي، ما في شيء بيشبه المغلي للام المطبخ. لا انا رح اشبلها، المغلي انا بعمله على ايدي، علمته الحال، ياخذ العقل، رح خليهم يجيبوا. نحن كمان تعلمناه من امهاتنا لما تخانوا. انا رح جيب لك المغلي اللي بعمله على ايدي، بدل حليب كثير. انا امي علمتني نفس طريقتك لما تخان. سلطاني خانم، بس انا عرفت شو صار. أولاد عم بسمع الكلمة، عم باكل وبشرب، بس ما عم تركوني اثنيناتهم.
صار وقت المجمع.
المرة بالنفاس ما بتلتفت لحالها. بس بشرب. لا ما بصير، انا كمان بقيت ما فيني اتركها لحالها بالصوت. شوفك اختي. شوفك ولاد. يلا بنتي تفضلي نام. اطلعي تنامي سلطاني خانم، يلا يلا.
جاهزين؟ جاهزين يا دكتور. دكتور عصام مجد. ماشي يا دكتور عصام. Good afternoon. Attention please. Good afternoon. Let us start a full steam ahead. So may I ask Dr. Arkadius from Poland to start just to make sure I'm okay. ان شاء الله نبدا ومؤتمر ناجح بيكم وبنشكركم، وانا عارف طبعا ممكن كانت الرحله صعبه شويه، لكن احنا جاهزين والسبيكر كلهم جاهزين والدكتور عمر جاهز، فدي اهم حاجه. شكرا. Can may I ask the moderator to start the session please?
مساء الخير. Thank you, Dr. Nasser. We're going to start our first session. I hope the speakers will stick to the time limit of 8 minutes. Per talk. We want to be finishing on time. Yeah, my name is Hussam Al-Sayed. I'm a vascular surgeon. I work in Norfolk, Virginia, and Eastern Virginia Medical School in the United States. I'm a graduate from Qasr Al-Aini University a few years ago, and happy to be here and share in this magnificent meeting. Hopefully it will be a great success for everyone.
Thank you very much for giving me the opportunity to be in front of you. It is a great honor to me. I will speak about hemodialysis vascular access affect heart function and outcome, tips for choosing the right access for individual patients. Disclosure, I have no disclosure. Cardiovascular disease is the leading cause of death in dialysis patients. Risk for this in dialysis patient with heart failure is 33% at 12 months, 46% at 24 months, 36% at 36 months. Patients with end-stage renal disease have cardiac problem due to renal failure, due to volume, water and salt retention cause volume overload, cause pressure load. Chronic anemia cause increase in the cardiac output, and the patient may already have significant pre-existing heart disease. AV fistula have superior longevity and lower infection, lower mortality rate, and lower cost, hence becomes a vascular access of choice in the renal dialysis patient, but also have significant effect on the cardiac function of the patient due to a change of the hemodynamics of the patient. Hemodynamics and unwanted effects of arteriovenous fistula just after creation of the AV fistula, the blood is shunting from the blood, reduce effective circulation volume of systemic circulation, which lead to activating the arterial baroreceptor, leading to increase in the sympathetic tone, contractility, and the cardiac output. Within weeks or months, especially with higher AV fistula, flow. Higher AV fistula mean flow more than 1,500 milliliter per minute. This lead increased in left ventricular end diastolic volume, increased in the left ventricular mass and size, increased in arterial chamber size, diastolic and systolic left ventricular dysfunction. Pulmonary hypertension, which mean pulmonary artery pressure higher than 25 millimercury at rest or exercise. Prevalence in renal end-stage renal disease is high, 56%, and most patients are asymptomatic. Symptoms are shortness of breath, dizziness, fainting, or leg swelling. Long-term effect, which is rare, coronary steal after coronary artery bypass, competition steal phenomena, competition between the left internal mammary aorta coronary bypass and ipsilateral upper extremity AV fistula. Central venous stenosis, frequent after dialysis catheter. High output cardiac failure which symptoms of cardiac failure, dyspnea at rest, edema in presence of normal cardiac index, which differ from congestive heart failure, and this is less than congestive heart failure in renal dialysis. Congestive AV fistula and congestive heart failure, heart not able to fulfill adequate organ perfusion by blood at rest or exercise. Highly prevalent among patients with end-stage renal disease, 35% to 40% of the patients with end-stage renal disease at initiation of dialysis. Classification of heart failure, New York Heart Association classification, type 1, cardiac disease, patient have cardiac disease but no symptoms or no limitation in ordinary physical activity. 2, mild symptoms and slight limitation during ordinary activity. 3, significant limitation in activity, symptoms comfortable only at rest. 4, severe limitation, symptoms even at rest. Another classification, the American College of Cardiology and American Heart Association, type A, at higher, the patient at high risk for heart failure but without structural heart disease or symptoms of heart failure. B, structural heart disease but without signs of or symptoms of heart failure. C, structural heart disease without period or current symptoms of heart failure. Type D, refractory heart failure requiring specialized intervention. According to the cardiac state, AV fistula or catheter. The cardiac state of each end-stage renal disease with or without heart failure should be one of the major criteria for selecting appropriate vascular access. It depends on clinical presentation of the patient. Life-threatening heart failure, catheter only. Left ventricular ejection fraction less than
2 minutes. You have 2 minutes.
Left ventricular ejection fraction less than 30%, catheter only. New York Heart Association Class 4 or American Heart Association Stage D, catheter. هي Class 3 Stage C, catheter. American Heart Association A, B, and C, distal arm AV fistula. New York Heart Association Class 1, Class 2, and certain 3, distal arm AV fistula. Take-home message: choosing the adequate vascular access is really a challenge. The decision between AV fistula access and the catheter should be individualized according to the degree of the cardiac involvement. Perform complete cardiac evaluation, include echo before choosing the AV access type. Thank you.
Thank you very much for a nice presentation. Yeah. My name is Arkadiusz Jawin, and as Professor Nasser Al-Said just said, I am from Poland, and I am chairman of the Department of Vascular Surgery and Angiology in the city called Bydgoszcz, which is in the northern part of Poland. And I want to thank you for a kind invitation for the, I think, already 4th time. And I always enjoy the meeting with you here and the quality of your work. But let's go to the next presentation. And I want to announce Professor Samek Mostafa, who is a professor of vascular surgery in Alexandria, in Egypt, and he's going to speak about the open access endovascular revascularization in critically ischemic lower limbs. Please welcome.
First of all, I'd like to thank Professor Nasser Said and members and board of VSE for inviting me to be here today. Good afternoon, everybody. Today, we are going to speak about open access endovascular intervention, a 3-center, 1-year experience. First of all, in 1994, Marin et al. Were the first to use open access endovascular treatment. This technique was adopted later on by EVAR, which is considered the prototype hybrid approach to apply an endoluminal solution through a surgical cut down. Many indications are known for open access, including chronic limb-threatening ischemia CLTI, which is a final stage of peripheral arterial disease scenario, could be due to diffuse tibial artery disease, or typically due to multi-level arterial disease, often needing correction. 25% of the patient with CLTI due to multi-level disease require combined correction of both aortoiliac segment together with the infrainguinal segments. And if it is done simultaneously in a surgical way, it entails a mortality of 19% and 61% morbidity. However, when we use a hybrid revascularization, mortality reduces to 1.4 and morbidity to 11 with a comparable limb salvage. Another indication here is acute thrombotic ischemia, which is a thrombus load on top of a diseased artery. Here, thrombolytic therapy is a nice option. However, it needs a time window for application and the results are not always optimal. Another indication is when we have a proximal lesion like this ostial SFA lesion combined with distal lesions like this, and we don't need to jeopardize the contralateral limb circulation, which is already jeopardized. Moreover, the tibials are long distance away from the transbrachial approach, and here is the role of open access. We conducted a study, an unrandomized prospective study, included 116 patients in 3 centers: Alexandria Vascular Unit, Tanta University Vascular Department, and Medical Research Institute of Alexandria. From June 2019 to May 2020, they were treated by different modalities, open access endovascular techniques, and followed for 1 year. The inclusion criteria included CLTI with multi-level disease indicated for hybrid revascularization, CLTI with a combination of tibial affection and proximal CFA or SFA artery affection, acute thrombotic ischemia rather for grade 2B, and failed percutaneous puncture for retrograde tibial access. The exclusion criteria included chronic lower limb ischemia other than Rutherford category 4 and 5, acute limb ischemia other than grade 2B, lesion anatomy not amenable for planned angioplasty, feasible contralateral approach and transbrachial approaches, life-threatening infection, and unfitness for anesthesia. These are the demographic data, comorbidities, and previous vascular interventions in the study patients. The clinical presentation included toe gangrene, foot ulcer, acute ischemia. The commonest were chronic ischemia Rutherford category 5 and acute limb ischemia. The procedure. The open access site included femoral popliteal, tibial ankle retrograde, and combined femoral and popliteal. The commonest were femoral and popliteal open access. Open surgery included common femoral endarterectomy, femoral popliteal bypass, aortofemoral bypass, thrombectomy for acute ischemia, and combined thrombectomy and arterectomy for ALI. The commonest was femoral popliteal bypass. The angiographic, the segment treated by angioplasty included iliac artery, SFA, popliteal, tibial. The commonest was the iliac with or without stents, followed by the tibial. The purpose for open access was angioplasty alone in 30 patients, like what we see in this patient. When we puncture the femoral artery, retrograde iliac approach, balloon dilatation of the common iliac artery stenosis, restoration of the circulation. After that, we reverse the sheath in opposite direction through the same puncture site to complete the action with the balloon dilatation of the SFA and the tibials. The other indication is hybrid revascularization in 86 patients, either in acute cases like this, after femoral thrombectomy, femoral endarterectomy, and closure with a patch. After that, we puncture the artery just proximal to the patch to have this image and complete the mission by balloon angioplasty of the SFA, and the limb was saved, but unfortunately with a residual ankle drop due to ischemic insult. The other indication is multi-level CLTI, as this case, where we puncture the common femoral artery here, iliac antegrade, retrograde access, balloon dilatation here. To conclude, open access endovascular intervention is feasible and can